Hello and welcome. My name is Whitney and I'm an anesthesia intern documenting my journey as I go through my first year of residency. I just finished up my fourth and final week of my emergency medicine block, so I am officially done with emergency medicine for my intern year. In today's video, I want to go a little bit over kind of like reflection of how the block went. I'll talk a bit about things that I liked, things that I think went well, and just overall my general thoughts about how it went. So let's go ahead and get into it. Okay, so I have three other videos dedicated to my time in the emergency room, like working during this block. And in those videos, I think I go over, or I try to go over the actual logistics of my time in the emergency room. So really talking about like the nuts and bolts, the very like objective information that I could figure out about working in the emergency room. For today's video, I more want to talk about like my feelings towards those things. So all the things I'm going to mention today, I actually feel like I mentioned in previous videos, but now instead of talking about it like very like matter of factly, I want to talk about more about my experience, like how I felt about these things. Okay, so the first thing that I want to reflect back on is the amount of effort it took for me to adjust to the actual goal of working in the emergency room. So I knew this going in, but I think just it's been a long time since I've actually worked inside the emergency room. I did that as like a medical student during my third year, so it's been a while. But the goal of the emergency room is to really figure out who is having an emergency that needs like immediate attention and who isn't, right? So some people come in and it's very apparent that they're having some kind of life threatening emergency that needs treatment right then and there. But that actually didn't happen all that much. It was a lot more of people coming in with symptoms, and we needed to figure out if they were having an emergency because of those symptoms or if they were not. So I'm saying that kind of carefully because I'm not saying we're trying to figure out an actual diagnosis for the patient. And instead, the main goal is just to figure out like, is there an emergency going on or is there not an emergency going on? Okay, so let's go over a bit of an example of what this actually looked like and like my feelings towards everything. So we'll go over an example of chest pain. That was a pretty common symptom that people would come in with. So when you're seeing a patient for chest pain, before you go into any patient encounter, you should be thinking about like a differential diagnosis, which is essentially just all of the things that could be causing chest pain. Now, in the emergency room, what's a little bit different is when you're making that differential diagnosis, you're really just thinking about the things that are true emergencies that could like kill this person quickly if they don't receive treatment. So that was a little bit different for me just because I'm used to more like internal medicine style of things where you're not just focusing on a more, I guess, limited or focused differential diagnosis where you're thinking about like every possible reason someone could have chest pain. But in this setting, you're really just trying to focus on like what could actually harm this patient like very soon, like very acutely. So that I think was the biggest change. So how this actually played out was, like you had your differential for emergencies for chest pain, and then you would create your workup for that patient. So every patient who came in with chest pain, you listened to their story and you decided like what tests you wanted to do for the patient to figure out if they had an emergency going on. Now, there were some patients where it was really easy, I should say, kind of like relatively, to figure out what's happening. Like they come in with chest pain and you, through your workup, like you get a diagnosis like very quickly, like let's say a heart attack or an MI, which means the same thing. But like, so we'll say a patient comes in with an MI and you get that diagnosis quickly and they need treatment quickly. So, that was pretty easy, feeling like you get a diagnosis and you know how to treat them. Honestly, that I wouldn't say that happened the majority of the time, though. A lot more of the time was a bit more of a gray area where you have a patient with chest pain and you do a workup for them, and either everything comes back normal and fine, or it's not exactly like a slam dunk diagnosis like that first example I talked about, but it's not normal either. Like it's kind of somewhere in the middle. So for the patients where everything comes back normal, in those cases, we really just tell the patient that, we don't exactly know what's going on, but we know that they're not having an emergency. So in those cases, we would be telling patients like, look, through our workup, we don't exactly know what's going on. We don't have a diagnosis, but we know that you're safe and stable to discharge home. So at this point, like, you can go home and you should follow up with your primary care provider so they can do further testing to figure out what's going on. The ones in the middle, though, the gray area, those were the ones where we would tell them, like, we don't exactly know what's going on. We don't exactly have a diagnosis, but we think you need further evaluation and treatment in the hospital. And for those patients, we would actually admit them. So you can see that there's a lot of variation in like how you handle patients, that I just like wasn't used to. I'm used to internal medicine where I feel like you get a diagnosis and you treat, and that's not exactly the goal of the emergency room. It's really just to figure out, like, is the patient having an emergency or are they not? And I think this was really hard for me to adjust to in the beginning, especially when it comes to those patients who come in with some kind of concern and then we find out that everything's fine. I feel like it was hard to tell patients, especially in the beginning of the block, like, to explain to them that, like, we've done our full workup and you have nothing acutely wrong with you that's going to harm you, like, right this moment, that doesn't need treatment, but we still think that you need further evaluation. It can just be done in the outpatient setting. And that was a hard conversation to have, especially in the beginning, just because I feel like people, which, like, this is very understandable, but they want to know exactly what's going on. Like, if they're coming in with a symptom, they want to know a diagnosis then and there. But, that's not really the emergency room's job. They're really just there to make sure that there's no emergency going on. Like I keep saying, right? Like, they just want to make sure that there's nothing that needs to be treated right then and there. And I feel like sometimes that's kind of unsatisfying for people to hear. And that was really hard for me to tell people, but eventually I got used to it more. And I feel like I just have like a better understanding of like the role of the emergency room. The second thing I want to talk about was the fact that I started to actually really feel like a doctor during this rotation. I'm not too sure if that was because it's my second rotation of the year and not my first one, or if it was actually being in the emergency room, but I really did start to feel more like a doctor. I had a really good day that I mentioned, I think in my last video or the video before, where I just like felt myself becoming more confident and felt myself really learning. And that was kind of my first time this year where I just like continually had interactions where I felt like that were going well and I felt like I was like doing the right thing without like having to ask someone. So that felt really nice. So that was one way that I felt more like a doctor. I could just like feel my confidence building up a little bit more. And I really hope that I continue to feel this way in other rotations during this year. But the other way that I felt like a doctor was the fact that I didn't really have anyone checking over my work, which I wasn't used to during my first rotation, where I did have someone looking over all of my work. So part of this came from my actual work on the computer of like putting in orders. I didn't have anyone like checking my orders, so I really had to put it on myself to make sure I was doing everything correctly the first time. So like putting in lab results or like imaging, there's like a tons of different types of tests you can do. So I really needed to make sure like I was figuring out like which one was the correct one. I'm sure I could ask, or I should say like I did ask my attending if I did have questions, but I just knew that it was on me to put it in correctly. So I kind of felt that like extra, maybe like pressure to do it right, which I think is like the right thing to do. Like I should be coming up with that responsibility and like going through with it. So that was the right thing. But also, I didn't really have my attendings checking over like physical exam findings, which I found really interesting because in my previous rotations, they had been. But like if a patient had like pulmonary symptoms, like I was the one listening to the lungs and the attending was the one, like going off of what I was saying. This was especially true for like sensitive exams, like pelvic exams and like digital rectal exams, which I like had to do a couple of. And like attendings aren't going to redo those things, so it was really on me to make sure that I was doing it thoroughly and correctly. And again, I think this was really good for me, honestly, because just knowing that there's not going to be someone else reviewing my work in that way, it made me realize like how important it is for me to be doing it thoroughly, so I'm doing it correctly the first time, because sometimes your management does change based off of physical exam findings. So I really needed to make sure that I was doing it correctly. And I will say that I'm glad that this is happening, just because I feel like there's just comes a point when you just need to do it and you need to like build the skills so you can trust yourself when doing these physical exams. So I think that's one thing I'm going to take away from this is I've heard this before, and I guess now I'll just put it into practice, but you really should be doing your physical exams to the point where with the thought that like no one else is going to be doing it. Like it's on you to figure out what exactly is going on and like really getting good at your physical exams because I don't know, you're not always going to have an attending to watch over you and do these things and check your work. So I think the sooner you get into that mentality of trying to get everything done yourself, I think the better the outcome will be when all is said and done. Okay, and the last thing I'll comment on is the actual schedule that I had during this emergency medicine block. And I'll have to say that I actually really liked it. It was less hours wise. It only worked out to like 4 days a week. The longest shift was like 10 hours, but I probably averaged closer to like 8 or 9 hours a shift. So I think the most I worked any week was like 38 hours, which really isn't that bad. I had a lot more time at home and a lot more free time, which was really nice. I will say that it is with a caveat, though, that even though I was working less hours, the shifts did go by pretty quick, but they were pretty tiring. They're kind of stressful just because there's so much going on. Even if it's not just like your patients, it's just like a very busy environment. So I feel like you just kind of like feed off of other people as well in terms of just like the craziness that's there. So the shifts went by quick, but they were longer weeks, I'll say. Like by the time the end of my fourth shift came around, like I felt very ready for a day off. So even though it was less hours wise, I would still say it was pretty tiring. But with that, I'll say that it was really flexible in terms of the hours, which I really liked. Like being able to start a little bit later sometimes meant I had mornings open, which was nice. But then other times I had, early morning shifts, so I had the afternoon open, and I kind of liked that variability just because I felt like I could get like do different things during different days. And I don't know, I just think it worked out really well. All right. Well, that is all that I really have to say about my emergency medicine block. Overall, it was different than what I was used to, but I feel like I learned a lot and did a lot, and I also was able to enjoy some personal time at home. So, overall, I would say it was a success. To end this video, let's go over how many hours I actually worked this week. So, I'll go ahead and pull those up here. And as you can see, I was kind of spoiled this week because I had multiple days off in a row. I even had Saturday of the previous week off. So I had, what was that, like 5 days off in a row, which was really nice. My first shift wasn't until Thursday at noon. And so, yep, again, these are 10-hour shifts, but you are only seeing patients the first 8 hours. And then after those 8 hours, you're just like wrapping things up. So I got to leave a little bit early on Thursday. Friday was a little bit different. It was a central line workshop that our residency program did. So instead of working in the emergency room, I actually just did like a short afternoon session of learning about central line. So that was pretty cool. We got to like practice on mannequins about putting those in. And then my very last shift of the emergency room was on Saturday, and it again started at noon. And I got off a little bit earlier at 9 o'clock. So, and then I had Sunday off. I think this is the lowest amount of hours that I've worked this year at just 20. So I was really spoiled this last week. All right, well, that is all that I have for you guys today. I have finished up the emergency medicine block, so I am next going on to an elective in ophthalmology or like eyeball stuff. So I will check in with you all next week after I have 1 week done with that. Take care, everyone.